This podcast episode is a special one as it dives into the bread and butter of pharmacy. And this podcast is made for listeners to better understand and grasp the challenging PK concepts and gives them the tools to apply to everyday practice.
Absolutely. And, navigating the intensive care unit is, well, it's essentially dealing with a human body in a state of total physiological rebellion.
Yeah, welcome to this deep dive, everyone, because, you are the one standing at the bedside of a critically ill patient, right? Alarms are blaring, you've got multiple bags of fluids and vasopressors on the IV poles.
And all the pressure is just squarely on you.
Exactly. And in those moments, it feels like you need to be a mathematician, a cellular biologist, and like a psychic all at once just to figure out how to dose life-saving antibiotics.
Right, because standard medical rules, those neat little textbook equations, they kind of just shatter when a patient enters septic shock. You're dealing with wildly fluctuating organ function and, massive fluid shifts.
Which is exactly our mission for this deep dive. We're taking that dense textbook jargon of pharmacokinetics and pharmacodynamics, PK and PD, and we're translating it into the ultimate bedside cheat sheet for you.
Which is so needed.
Yeah.
Because the bugs are actively trying to kill the patient, and you don't have time to flip through a textbook.
Well, you really don't. So let's start with the basics. We all know the classic ADME acronym from day one, right? Absorption, distribution, metabolism, and excretion.
Right.
But in the ICU, we get a bit of a cheat code. Because your antibiotics are being pushed intravenously, we get to bypass the A entirely.
Yeah, absorption is just always 100%. The drug goes straight into the bloodstream.
So we get to skip the front door and jump immediately into the chaos of the distribution phase.
And that's a huge shift. Bypassing absorption gives us an immediate guarantee of drug delivery, but, and this is a big but, it introduces our first major hurdle.
Where does the drug actually go?
Exactly. Once that drug is injected directly into the veins, you have to understand where it ends up. Because the blood is just the delivery highway. It's rarely the final destination.
It has to penetrate tissues, cross membranes, find the actual infection. Okay, let's unpack this. The term volume of distribution is thrown around constantly.
All the time.
But it can sound incredibly abstract when you're just staring at a patient's chart. So I want you, the listener, to just picture a bathtub.
A bathtub is a great way to look at it.
Right. The volume of distribution is essentially the theoretical tank that you need to hold the amount of drug you just administered, just to maintain the specific concentration you're seeing in the patient's blood plasma.
Yeah, if you need a specific drug concentration to kill a bug, you absolutely must know how big the bathtub is so you know how much drug to pour in.
But in the ICU, that bathtub isn't normal, is it?
Not at all. In a healthy ambulatory person, that bathtub is a relatively fixed, predictable size. But the ICU strips away all that predictability.
Right.
In a critically ill septic patient, that bathtub is constantly morphing.
Because sepsis triggers that massive systemic inflammatory response.
Exactly. The endothelial lining of the blood vessels gets damaged, and the capillaries literally become porous. They leak.
And then we're adding aggressive intravenous fluid resuscitation into that mix, right? We're often pumping liters upon liters of crystalloids into these patients just to keep their blood pressure up.
Yeah, and all that fluid shifts out of the blood vessels and third spaces into the surrounding tissues.
Which you physically see when a patient becomes incredibly edematous, just ballooning up with fluid.
Right, and all of that intervention physically expands the theoretical tank. The drug just follows that fluid out of the central circulation and into the peripheral tissues.
So the plasma concentration of your antibiotic just plummets.
It plummets because it's being severely diluted by this newly expanded, completely waterlogged space.
So the bathtub basically just turned into a swimming pool.
Exactly, a massive swimming pool.
But looking at our sources, not all drugs react to this expanding pool in the same way, right? We have a crucial split here based on the drug's chemistry.
Yeah, it really comes down to whether an antibiotic is hydrophilic, meaning water-loving, or lipophilic, meaning fat-loving.
Let's look at the hydrophilic heavy hitters first. Vancomycin, ceftriaxone, meropenem. Because they love water, they naturally stay confined to the blood and extracellular fluids.
Right, that gives them a much smaller volume of distribution to begin with, usually somewhere between, 7 to 69 liters.
So because their starting volume of distribution is so small and restricted to those water compartments, a massive influx of resuscitation fluids heavily impacts them.
Heavily. The drug gets drastically diluted. You administer what looks like a perfectly standard dose on paper, but because The tank has massively expanded with all that third-spaced water.
The concentration floating around in the blood ends up being completely subtherapeutic.
Exactly. You are literally leaving the bacteria alive to multiply.
Okay, let me make sure we are drawing the line clearly for the listener here. If a patient is ballooning with IV fluids, does that mean the hydrophilic drugs are essentially getting washed out in the extra water?
Yes, that is exactly what it means. They are just lost in the flood. But, and this is key, lipophilic drugs don't really care about the extra water.
Wait, really? Why not?
Well, take ciprofloxacin as the perfect counterexample. It's highly lipophilic. It naturally wants to escape the watery blood plasma and distribute deep into the body's lipid and fat tissues.
Oh, so it's already spreading way outside the bloodstream.
Yeah. Because it spreads so far and wide into the solid organs and fat, ciprofloxacin has a massive baseline volume of distribution, often 150 liters or greater.
Wow. So the bathtub for ciprofloxacin was already the size of a lake before the patient even got sick.
Exactly. And when you add 5 extra liters of resuscitation fluid to a lake, the overall water level barely registers a change.
That makes total sense. So the clinical takeaway at the bedside is that a lipophilic drug like ciprofloxacin is going to be incredibly resilient against these critical illness fluid shifts.
Right. Whereas your hydrophilic drugs like vancomycin or meropenem are going to suffer massive drops in plasma concentration.
And honestly, that distinction alone can save a patient's life. Okay, so we've established the size of the tank and how sepsis and fluids stretch it out.
Yep, the distribution phase.
But if the tank was just sitting there, we could stop. The problem is the tank is actively draining. Which brings us to the next massive piece of the puzzle, how fast the body eliminates the drug.
Right, metabolism and excretion. And the liver acts as the body's chemical modification factory here. It metabolizes drugs through phase I oxidation, utilizing the cytochrome P450 enzymes.
And phase 2 conjugation reactions to make drugs easier to excrete.
Exactly. And sepsis can certainly impair this factory through hypoxic liver injury or altered hepatic blood flow. The exact effect on the metabolism of specific antibiotics is pretty complex, but it usually trends towards slowing things down.
Slowing it down, right. But the main drain we really need to watch for antibiotics is the kidneys, renal elimination.
The kidneys are the main event here.
But wait, hold on. We always associate severe critical illness with organ failure. If my patient is in the throes of septic shock, their creatinine is probably climbing and their kidneys should be shutting down, right?
You would think so.
So why does the source material warn us about augmented renal clearance? Why would their clearance actually go up?
It's crazy, right? It is one of the most dangerous, counterintuitive phenomena in critical care. Yes, kidneys fail in the later decompensated stages of shock.
Right.
But in the initial hyperdynamic phase of sepsis, assuming the patient has received adequate volume resuscitation, the body is fighting back. The heart compensates by pumping furiously. Cardiac output can literally double.
Oh, wow. So it just blasts blood through the kidneys like a fire hose.
Exactly. The glomeruli are suddenly seeing massive blood flow, so they start filtering out the drug at double the normal speed. They are working on complete overdrive.
So the drain is wide open. Who is most at risk for this?
The sources highlight specific risk factors to help you anticipate this. You'll see augmented renal clearance in patients with young age, multi-trauma, and limited baseline comorbidities.
So think of like a 25-year-old motorcycle crash victim.
Perfect example. They have massive physiological reserve. Their body can easily recruit that extra cardiac output and renal function. And the sources explicitly note it is not caused by advanced age or prolonged ICU stays.
So the 80-year-old in cardiac arrest isn't going to have this?
No, they won't. It's the young, resilient patients.
Okay, so we have a chaotic tug-of-war happening simultaneously. The capillary leak in fluids are pulling the volume of distribution wider, making the tank bigger.
Right.
Meanwhile, augmented renal clearance is pulling the drain wider, emptying the tank faster. And this tug-of-war dictates the drug's half-life.
It does.
I promised we wouldn't do boring math, but the half-life formula beautifully illustrates this bedside reality. The formula is half-life equals 0.693 multiplied by the volume of distribution divided by clearance.
Let's ground that with a concrete example for everyone.
Let's do it.
Say you have an antibiotic with a volume of distribution of 100 liters and a clearance rate of 10 liters per hour. You multiply 0.693 by 100, then divide by 10. You get a half-life of roughly 6.9 hours.
Right. But let's be real. Nobody is standing at the IV pole multiplying by 0.693 in their head while alarms are going off.
Definitely not.
The exact number isn't the magic part. The magic is visualizing the seesaw effect. Volume of distribution is in the numerator. It has a direct relationship with half-life.
Right.
If you pump a patient full of fluids and their tissues swell, the volume of distribution goes up and the half-life increases. The drug takes longer to clear because it's hiding out in all that extra fluid space.
If we connect this to the bigger picture, clearance sits in the denominator. It has an inverse relationship. If clearance increases, like our young trauma patient blasting blood through their kidneys with augmented renal clearance, the half-life plummets.
The drug leaves the body far faster than the textbook says it should.
Exactly. Understanding this mathematical tug-of-war allows you to make logical, rapid predictions about drug behavior based entirely on the specific pathophysiology of the patient in the bed right in front of you.
So if the kidneys are acting like an open floodgate and the half-life is plummeting, we are losing the race against the bacteria before we even start.
We are.
How do we instantly overcome that massive, leaky tank? We have to force the issue.
Which brings us to the most critical decision of the first hour, the loading dose.
Yes, the loading dose. Because the goal of starting an antibiotic infusion is to reach steady state.
And steady state is that optimal equilibrium where the amount of drug entering the body perfectly matches the amount leaving, right?
Exactly. It's the zone where bacterial killing is maximized. Now, pharmacokinetics dictates that it takes about 4 to 5 half-lives to reach 97% of steady state.
Wait, so let's say we have a drug with a 12-hour half-life. Waiting 4 to 5 half-lives means waiting over 2 days to reach the optimal therapeutic concentration. Yeah, and waiting 48 hours for your antibiotics to fully kick in during septic shock is an absolute death sentence.
You can't do it.
No. A loading dose completely bypasses that dangerous waiting period. You push a large bolus up front to immediately force the drug concentration up to that optimal steady-state level.
Right.
And here is the golden rule of loading doses. And it is a trap that catches brilliant clinicians every single day. The loading dose depends only on the volume of distribution.
I'm going to say that again. That is the line to highlight, underline, and circle in red.
The loading dose depends only on the volume of distribution. It has absolutely nothing to do with renal clearance.
Nothing at all. Consider the mechanism. A loading dose is just filling the tank for the very first time.
Yeah.
If a patient is in acute kidney injury and hasn't made a drop of urine in 12 hours, their clearance is functionally 0.
Right.
It feels terrifying to order a massive 2-gram dose of vancomycin for a patient whose kidneys have failed. Clinicians often flinch and artificially reduce the initial dose out of fear of toxicity. But because the loading dose is based entirely on the size of the tank, lowering the dose means you fail to fill the tank.
Exactly. You guarantee the patient will be subtherapeutic during the most critical window of their infection.
Going back to our analogy, you still have to fill the bucket to the top on the first pour, regardless of whether the hole in the bottom of the bucket is big or small.
That's a great way to put it.
If you want the water level to reach the rim immediately, you pour a full bucket's worth of water. You only worry about the size of the hole at the bottom when it's time to add maintenance water hours later to keep it full.
Yes. You give the full loading dose always.
But there's always a fascinating exception to study, right? Our sources highlight meropenem as a brilliant contrast to vancomycin here.
They do. Meropenem is highly hydrophilic and barely binds to proteins in the blood.
So it has a very small volume of distribution.
Right. But more importantly, it has a blistering half-life of just 1 hour.
Oh, wow. Just 1 hour.
Yeah. Because the half-life is just 1 hour, 4 to 5 half-lives means meropenem naturally reaches steady state in just 4 to 5 hours.
Oh, I see.
Since the tank is small and it reaches steady state almost immediately on its own, a loading dose is far less clinically significant for meropenem than it is for a drug with a massive volume of distribution and a long half-life.
That makes total sense. You can often just start the standard infusion and it hits the therapeutic target rapidly.
Exactly.
Okay, so we filled the tank, we gave our full, unapologetic loading dose based purely on the volume of distribution.
Yep.
We understand how the kidneys are either hoarding the drug or dumping it out like a fire hose. Now we have to cross the bridge from pharmacokinetics, what the body does to the drug, over to pharmacodynamics.
What the drug actually does to the bugs.
Exactly. We have to hit our specific killing targets.
Because different classes of antibiotics have entirely different mechanisms of lethality. They require distinct bedside strategies to maximize their destruction of bacterial colonies.
And our sources lay out 2 primary distinct treatment goals for the antibiotics we've been discussing.
They do.
This is where we elevate from just following a protocol to actively hunting the infection. Let's dig into the why behind these targets. The first goal is time-dependent killing.
Right. Time-dependent killing is all about the time spent above the minimum inhibitory concentration, usually written as T greater than MIC.
Okay.
This is the exclusive strategy for your beta-lactam antibiotics, which include your penicillins, cephalosporins like ceftriaxone, and carbapenems like meropenem.
But why do they only care about time? I mean, why wouldn't we just give a massive concentrated dose to blast the bacteria?
It's because of how they work on a cellular level. Beta-lactams kill bacteria by binding to penicillin-binding proteins and halting cell wall synthesis.
Right.
But they can only do this when the bacteria are actively dividing and trying to build new walls. Spiking the drug concentration to 100 times the minimum inhibitory concentration does absolutely nothing extra because the bacteria can only divide so fast.
The drug just sits there waiting.
Exactly. It just sits there.
It's like trying to ground something. You just need to keep their heads underwater continuously. If the concentration dips below the MIC even for a little while, the bacteria come up for air, resume building their cell walls, and recover.
That's exactly it. You just have to keep them submerged.
Yeah.
Now, the second major pharmacodynamic goal is a combination target known as the 24-hour area under the curve to MIC ratio, or AUC to MIC.
Okay, AUC to MIC.
Yeah. This is the target for vancomycin and fluoroquinolones, like ciprofloxacin.
Area under the curve sounds like calculus, but it's really just a measurement of the total drug footprint over an entire day.
Precisely. These drugs don't just rely on the bacteria actively dividing in a specific moment. Their lethality is driven by the total overall volume of molecular exposure the bacteria suffer over a 24-hour period.
So you need a massive total aggregate amount of drug circulating relative to how resilient that specific strain of bacteria is.
You do.
Here's where it gets really interesting. Let's put you, the listener, back at the bedside. It is day 2.
Okay, day 2.
The patient's creatinine has spiked, meaning they are developing severe renal dysfunction. Clearance is dropping. We know we gave the full initial loading dose yesterday to fill the tank, but now the drain is clogging up.
Yeah, the drain is plugged.
How do we adapt today's maintenance doses based on these two very different bacterial killing goals?
Well, across the board, because clearance is significantly reduced, the overall daily maintenance dose must decrease, or the drug will accumulate and cause severe toxicity.
Right, that part is obvious.
But the exact strategy of how you decrease it is where your advanced PK/PD knowledge dictates the outcome. Let's take the time-dependent beta-lactams first, like ceftriaxone and meropenem.
Where their only goal is to stay above that MIC threshold for as many hours of the day as possible.
Exactly. Because the drug is clearing much slower due to the kidney injury, it is naturally going to stay above that threshold longer on its own.
Oh, right.
Therefore, the most effective adjustment is to keep the actual milligram dose exactly the same, but drastically increase the interval between those doses.
So you still deliver the same strong punch, but you wait 8 or 12 hours longer to throw the next one, ensuring the blood level never drops below the droning point.
You've got it. But what about our AUC-dependent drugs, vancomycin and ciprofloxacin, where we care about the total daily footprint?
Yeah, how do we adjust those?
For AUC-dependent drugs, you technically have 2 mathematical options to reduce the daily accumulation. You can stretch out the interval, just like we did for the beta-lactams.
Okay.
Or you can keep the interval the same and lower the actual milligram dose given each time. Pharmacokinetic modeling shows that lowering the actual dose produces the smallest negative impact on the total area under the curve.
Oh, wow. So lowering the dose preserves the total 24-hour footprint better than stretching the interval.
Exactly. Keeping the interval tighter but with smaller doses ensures a more consistent total daily exposure for these specific drugs. It maintains the best continuous efficacy against the bacteria while still protecting the failing kidneys from toxic accumulation.
Lower the dose for vancomycin to preserve the AUC, but stretch the interval for meropenem to preserve the time above MIC.
That's the secret.
I mean, that is the kind of profound bedside pearl that separates a protocol follower from a true critical care clinician.
Absolutely.
We have covered some intense physiological ground today. Let's retrace the steps of our bedside cheat sheet before we wrap up.
Sure. We started by bypassing absorption entirely. We visualized the volume of distribution as a dynamic bathtub that heavily dilutes hydrophilic drugs like vancomycin when sepsis and aggressive fluids cause it to overflow.
While lipophilic drugs like ciprofloxacin safely hide out in the tissue compartments unaffected.
Right. Then we watched the kidneys act like a fire hose during the hyperdynamic phase of trauma, creating augmented renal clearance that severely drops our half-life.
And we learned the golden, unbreakable rule of the first hour. Fill the bucket on the first pour. The loading dose depends purely on the volume of distribution and must be given in full, even if the patient's kidneys have completely failed.
Yes. Finally, we applied the mechanisms of bacterial death to our daily maintenance. We stretched the dosing intervals for time-dependent beta-lactams to keep the bugs continuously underwater.
And we lowered the individual doses for vancomycin to preserve the total daily area under the curve.
It is the difference between memorizing a static algorithm and actually understanding the chaotic living mechanics of the human body.
It really is. And that brings us to the end of our deep dive. But before we sign off, I want to leave you with a final thought to mull over during your next rounds.
It's a really important one.
Yeah. Our sources emphasize that this kind of personalized, moment-to-moment bedside application is absolutely essential because the gold standard literature we rely on has a glaring blind spot.
Right. Think about standard randomized controlled trials. By their very nature, they require rigid, perfectly controlled clinical parameters to achieve statistical significance. They study patients in neat, predictable boxes.
Yeah, they have to.
But when you consider the wildly fluctuating, minute-by-minute physiological storms altering the volume of distribution and clearance that we just mapped out, how much of our accepted standard medical literature is completely blind to the chaotic reality of the critically ill patient actively crashing in the bed right in front of you?
It's a wild thought. It really makes you wonder if our rigid dosing guidelines were built for a calm, static bathtub while you are out there actively trying to manage a hurricane.
They probably were.
Thank you so much for joining us on this deep dive. Take these concepts, look closely at those fluid shifts and kidney functions, and we hope you feel significantly more armed and ready to navigate the murky, unpredictable waters of the intensive care unit.